Um, um, Good morning.
Hey James, how you doing?
Good, good. Can you hear me?
Yeah,
Suresh, good morning.
Good morning, James. Looking forward to another great lecture from you today. And good morning, James, and also to John.
good
Okay,
morning. How you
looking
doing?
forward. Okay. Will you be coming to Boston next week, 2 weeks time, James? AANS.
Yes, I'll be there for the Gill Society.
Yeah,
I won't be able to stay for AANS, but yeah, I'll be there.
oh, I too will be there for Yasragil meeting. Okay, we'll see in 10 days time. Very
Okay.
nice. Okay, looking forward. Okay, to today's
Okay.
lecture. Okay.
There's a lot of people going to Boston.
Sergey, is our moderator and panelists registered into the room?
Mm, Here's Everett, there'll be a lot of
Hi,
latecomers.
how are you?
Hello, good morning.
Good morning.
Okay, Everett, how you doing? I'm Dr. Bennett. You need to, there you go. Beautiful. Okay. So, Burdenko, wow, that's quite credentials.
Thank you. Thank you.
We'd like to establish some ties with Burdenko. We've been trying over the years. But we'll talk about that later. I'll send you an email.
Perfect.
Uh, see, Jamie's catching our plane, right?
Yeah, a
Okay.
little later.
Okay.
So thank you for moving it early.
Yeah, that's fine. No problem. I mean, doctors, 7 o'clock is not early to a neurosurgeon. That's sleepy. That's sleepy in.
Yeah, yeah.
But we'll start and because
Is Raphael logged
yeah,
in yet?
he asked me and I sent him the link. So we can wait a second, I guess.
Does Andrea have the link too?
Oh, here he is. Yeah.
Okay.
Professor James, good morning.
Good morning.
Morning.
Morning, Raphael. How you doing?
Professor James,
Great.
bonjour.
Yourself?
How are you?
Good, good. How are you?
Good. Here we are.
I'm great.
Okay, we'll start, James. Okay.
It's been a while.
Okay.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Hold on. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. Today we have a webcast with James Leo, a frequent broadcaster with the Art of Brain Surgery Masterclass. And I'll let Rafael Martinez Perez, an old friend from, he's up in the Poconos in Pennsylvania with Geisinger. He's going to be the host today. I'll take it over, Rafael.
Hello, guys. So, should I just move on, John? I'm sorry.
Yeah, Andrew, yeah, could you please introduce James?
Yes. So, hello, guys. So, James Liu is a skull-based neurosurgeon at New Jersey. He's in the group of neurosurgery at New Jersey. He's also working at Rutgers as a full professor and show us this big teaching about the Falcotentorial meningiomas. So, Jim.
Great. Thank you, Raphael. It's great to see you here.
Oh,
And Ervik and John, thank you for arranging this. Let me go ahead and share my screen here.
Hmm.
Okay. Can you see my screen?
Yeah, it's not perfect. There you go. Perfect.
Okay, terrific. Well, thank you again, and welcome to the second installment of the Art of Brain Surgery Masterclass. And today I wanted to focus on a topic that is near to my heart. I call it Journey to the Center of the Brain. And a lot of this is sort of is due to what inspired me to go into neurosurgery, is just the thoughts of when you see these different lesions, tumors or vascular lesions that are in the deep parts of the brain. I was intrigued by how does one get there and take care of these problems without causing any injury or violation to the brain structures. And so I wanted to focus on some of the routes that are not so common to us, not so intuitive, and I call it the roads less traveled. So I hope you enjoy this, and we'll show you some tips and tricks and nuances that will help you do better for your patient and to better deal with these sometimes difficult lesions. So the routes to the deep areas of the brain and the skull base, as you know, as skull base surgeons, we have to master all the different approaches, all the different open approaches that you see on the left in a 360 fashion, and then all of the endoscopic endonasal approaches. And these are to lesions of the skull base. And we talk about these approaches in different episodes of this series, but today I wanted to focus more on tumors that are in the deep ventricular system and the pineal region. So mostly in the third ventricle and this area of the pineal gland. So this is, I mean, this is what you would say is the center of the brain, you know, the core, the nucleus, if you will, the center of our earth. And as you can see, there are a lot of important structures here. Within the third ventricle, the roof is lined by these important paired veins called the internal cerebral veins. And posteriorly, you have the pineal gland that will exit into the pineal recess. And you have these important arteries that are your medial, posterior choroidal perforators. And the choroid plexus, as it runs along the floor of the lateral ventricle going into the foramen of Monro, is an important and useful landmark that you'll see at some point. And it's also important to know where the fornix are, the fornices. The fornix is involved with cognitive function and memory, and you don't want to injure the fornices at all costs, because this can be devastating to the patient. So Professor Roten taught us many different corridors to the ventricular system, depending on whether you're in the anterior lateral ventricle, the posterior of the lateral body, and of course, foramen Monro going to the third ventricle, cerebral aqueduct, and fourth ventricle. And these are all the different transcortical avenues to get there. And that violates, you know, brain structure. But what about taking natural crevices or natural fissures that can get us into the brain without having to violate the cortex of the brain? These are the interhemispheric approaches, and it's much like these mountaineers climbing into the deep parts of these canyons, going through natural crevices. So let's go through some cases. This is a classic appearing central neurocytoma. You can see this is a large intraventricular tumor. These often arise from the septum pellucidum, and this patient was having severe headaches. And also you can see there's a acquired Chiari here, probably from increased intracranial pressures pushing everything down. Mostly it's in the left lateral ventricle. You can see it's pushing the septum over to the right. And it's a slightly more dilated ventricle on the left. So when we do these in the interhemispheric approach, you can either consider going transcortical. Often many surgeons will choose a transcortical approach. It gives you this view, but there's a risk of not being able to see this upper corner. So you have a potential blind spot in this area. So I believe that if you go transpilosal, you have equal opportunity to get to both sides of the ventricle. So when we do these in the lateral position, it's important to decide which side is going to be on the top side, the superior side. So in this case, I chose the left side up because the left side, like I said, had a larger component, and due to gravity falling downwards, I find it easier to put the larger portion of the tumor on the top side than to trying to look downwards on the opposite side. And hopefully this will make more sense as you see the videos. So it's important to keep the angle of the falx about 30 degrees from horizontal, and this will give you a natural line of sight. And when I do the bone flap, I will prefer to take the bone flap across the midline so that you can retract the superior sagittal sinus by a few millimeters. And those few millimeters, I truly do believe that it makes a difference in your ability to see. So every millimeter counts. So we're going to put the left side up, and we'll go interhemispheric. And you'll see here, this is the right frontal lobe by gravity falling away from the falx. It makes opening the interhemispheric fissure a lot easier when you do this in the lateral position, because natural gravity, you don't need retractors. You can just mobilize the frontal lobe, find the arachnoid bands, and just slice each arachnoid band. And then using a spread technique, we identify the callosal marginal arteries and then eventually the pericallosal arteries. And you want to find the white color of the corpus callosum. And that's how you can tell the corpus callosum from the cingulate gyrus, is that the corpus callosum is white and will enter the tumor, which has a gray appearance. Often these central neurocytomas often are kind of friable, very suckable. And so you could debulk a lot of this just with your suction. I generally use a 7 French Fukushima suction. And now I'm peeling the tumor from the floor of the lateral ventricle. I'm just using a gentle traction and then spreading technique with my forceps, and then using the suction. You can use a suction to use a gentle sweeping to gentle suction dissect the tumor off of the floor. And you can see that's the last component of the tumor. And now you can see the floor of the ventricle. That's the third ventricle down there. That's the chordoplexus going into the foramen Monro. And we're just inspecting now. You could see now we can open up this foramen, go into the third ventricle that we'll see here. This thing widened the ipsilateral foramen Monro on the left. And we'll use an endoscope. Endoscopes are very useful. You can see a spectacular view of the atrium. This is looking all the way back into the posterior atrium. This is the thalamic caudate. This is the head of the caudate. Oftentimes these tumors are adherent to the caudate, and you just use a little bipolar to release the tumor from the surface of the caudate, and you can achieve this type of resection. So this is a complete removal, no violation of the cortex. He's neurologically intact. He did require a shunt. He had delayed hydrocephalus, and but he's normal, and he's been recurrence free for roughly 5 years now. So a great favorable result here. This is another tumor. This is a big atrial ventricular tumor. He had existing field cut here on the left, and he presented with seizures. And so in this case, in terms of the choice of approach, I thought about either coming interhemispheric and coming in precuneal to get into the ventricle. This thing came so close to the surface. Could I come in transtemporal? And I eventually decided to just come in along the long axis of the tumor. He already had a pre-existing deficit. And so we made the incision here posteriorly. I had two options. I planned out for two different options, but I ended up taking this simple linear incision, going for the simple solution. And so here's the entry point, using image guidance and stealth to map our trajectory. Again, going along the long axis of the tumor, and you very quickly come down on the tumor capsule. This was kind of a firm, fibrous tumor. And so you could see it's kind of invading around the white matter. surrounding the ventricular system. So you just simply cauterize and separate it from the surrounding white matter, and we eventually get into the ventricle. The way you could tell you're in the ventricle is you could see the ependema, the nice shiny white lining of the ependema, and we'll dissect away the tumor here. And then we'll use cottonoid patties to separate the tumor from the ventricular walls. You can see there's some small little vascular feeders that you can cauterize. And of course, you want to debulk the tumor as well and make the tumor smaller. But just continued circumferential dissection. Now, this part here, this is the lateral part. This patient is in a lateral position. So this is the temporal lobe being elevated upwards. So in fact, it's being elevated laterally because by gravity assistance, the temporal lobe is going to want to fall down into your field. So we just have to hold it up as a brain holder and then continue to work patiently around the tumor circumferentially. And then once we've isolated it, we'll debulk the tumor using this ultrasonic aspirator. And once we make the tumor smaller, it'll be a lot easier to deliver. And so here is the release of the tumor. And we're just piecemealing it at this point, making sure we get every component of it. But the tumor has been devascularized and detached. And here are the ventricular walls. This is the ependema of the lateral ventricle. You can see the choroid plexus in the depths there. Just making sure there's no residual tumor and so forth. And so here's the final view. You could see not a very big opening, but plenty to remove this large tumor. And this patient remained neurologically at his baseline. And this is the 3-month post-op scan. So these were the lateral ventricular system, but what about as you get deeper into the third ventricle? This is from Roten's Atlas. You could see there's the different avenues to get to the third ventricle, whether the lesion is in the anterior third or posterior third can help determine which approach you take. I want to focus on the anterior third ventricle first. There's different ways to drop into the third ventricle. You can either go transcortical or transcallosal, depending on the lesion. But once you're in the lateral ventricle, what are the different ways to get into the third ventricle? Well, there's the transforaminal, the simple going through the foramen, but you're going to need a big foramen to do that. But if the foramen is small, you can alternatively open up the choroidal fissure. As you see here, you have to divide the septal vein and then open up the choroidal fissure, and that can open up that route. And the route here is going to be more oblique, so you're going to have a better view of the ipsilateral side of the third ventricle, or I'm sorry, contralateral side of the third ventricle, because you can see the opposite wall. But there are some blind spots on the ipsilateral side. And the road that is not as commonly traveled is this interforniceal route. And it's where you go in between the two fornices. You have to separate the septum pellucidum first, and then find the cleft where you could separate the two fornices to drop into the third ventricle. And I really like this approach because it gives you equal opportunity to view both sides of the third ventricle. It's a more strictly midline approach, but it's often been abandoned because of the fear of interforniceal injury, which is a real thing. And you don't want to injure the fornices. This can severely impair the patient. But let me show you some tricks that I've used over the years that I think has helped and has made this approach feasible. So this is a large colloid cyst. She had hydrocephalus and was shunted in another hospital. She now presents with enlargement of her colloid cyst. And you could see the ventricular system has collapsed, so you can't really use a transcortical approach here. So your option here is what I felt was to be a transcallosal approach. And so I'm opening up the corpus callosum now. This patient is in the lateral position, and you could see there's the shunt catheter in the ventricular system, and there's the septum pellucidum being widened and being pushed. So now I find the interforniceal cleft. There's the colloid cyst, you could see. And I'm using an 11 blade here. I'm trying to identify the two leaflets of the septum pellucidum. I eventually get down to the cyst. I try to maintain the turgor as much as possible. You don't want to lose the cystic contents because the turgor of the cyst allows you to dissect it against the walls. But you'll release a little bit of it. You let a little bit of the contents come out of the cyst. And then we can begin to separate the colloid cyst off of the walls of the third ventricle. You can see the beautiful ependema and the floor of the third deep in there. So we're controlling the anterior margin of the cyst, getting it away from the foramen of Monro that you see here. Here's the foramen of Monro. And then posteriorly, there's usually some choroidal perforators attached to the backside of the cyst. And once you release those perforators from the backside, from the pineal cistern, we can start to deliver the remainder of this colloid cyst. And this is probably one of the largest colloid cysts I've removed to date. This is not your typical colloid cyst, but this is what happens when you just shunt and say, okay, that's it. I'm treating the patient with a shunt. They will continue to grow. This is a third ventriculostomy. We could see the basilar artery, and we'll inspect, make sure the fornices are all intact. And indeed they are. Beautiful view of the third ventricle. And this is the post-op scan. And she did not have any memory deficits or cognitive impairment. She was back to work. And a cure. This is a surgical cure, whereas a shunt is not a surgical cure. It's just a temporizing measure. So another case, this is an interesting lesion. You see there is a lateral ventricular lesion here, and then another third ventricular lesion with proteinaceous content. I originally wasn't sure if this was one single tumor, maybe a cyst that had expanded, or maybe if are these two different tumors. In any event, we explored him with this time I went from a transcallosal approach. In this situation, I believe I did the left side down this time, but this is the lateral position. And we get into the lateral ventricle, and this is the lateral ventricular tumor. It's kind of have a gray, whitish appearance, not very vascular. So this tumor in the lateral ventricle ended up to be a subependymoma. So you had two different lesions here. So here we're using the scissors, and using the tip of the scissors, you can use it as a dissector, and you can gently peel and cut at the same time. It's a scissor sweeping motion. And this is how we were able to dissect the lesion off of the septum pellucidum, off of the fornix carefully, and off of the floor of the lateral ventricle. So you cannot do this with a blunt Roten 6 dissector. You know, many young surgeons I see use a number 6 Roten as their go-to instrument. But if you can master scissor work and master the art of sharp dissection, you become very versatile, and you'll never ask for a Roten 6 again. Maybe for dissecting a neck of an aneurysm where you need more gentle, blunt instrument. But learn how to use the scissors effectively, and you'll never use a blunt instrument in 95% of your cases again. So there you go. There's the tumor being removed. This is the lateral ventricular component. There is the fornix. You can see the fornix is untouched. unharmed, and you don't see the colloid cyst through the foramen of Monroe. So what do? You have to come from the top, open up the septum pellucidum leaflets, get into the interforniceal corridor, because the cyst is in the roof of the third ventricle. It's high up. So it's going to be very difficult to see from a transforaminal approach. Only a component is peeking through the foramen. So what I'm going to do now is I've opened up and controlled the superior aspect of the colloid cyst, and then I'm going to push it down into the foramen of Monroe window. So I'm using both windows to my advantage. I have both windows accessed. You can see this colloid cyst was very adherent to the third ventricle, and I've now used a gel foam. You can see the gel foam here is pushing the colloid cyst back into the foramen Monroe, and now I can deliver the rest of the colloid cyst through the foramen of Monroe. These cysts are very adherent to the choroid plexus. There's usually a lot of vascular perforators, so when you do these through a purely endoscopic approach, the instrumentation that's using to remove it is a suction aspirator. So you don't have the ability to do this fine micro dissection of cauterizing and cutting these small perforators. And, the endoscopic approach in my mind has more risks. Using those power tools, you can risk suctioning and injuring the fornix, and that can lead to cognitive impairment. So this ability to dissect and precisely cut and separate and disconnect these cysts from important critical structures is a huge advantage, but it preserves neurological function and can avoid forniceal injury. So here's the post-op scan, a complete removal, and the patient was neurologically intact. Now, what about posterior third ventricular lesions? You can also get to the posterior third ventricle. We talked about the anterior third ventricle, which are mostly colloid cysts. But here's a posterior third ventricular lesion, all the way back near the pineal region. You can certainly choose a classic pineal approach, the supracerebellar infratentorial. But when they're in the posterior third ventricle, my preference is just to continue to use the anterior transcallosal corridor and just aim the trajectory a little bit more posteriorly. Originally, we aimed more straight downwards to the colloid cyst lesions, but if you just aim your microscope and your callosotomy more posteriorly, you can easily get to the posterior third ventricle, which I'll demonstrate here. Again, here's the dissection of the interhemispheric fissure. You can see, just using gentle traction, you can see where the bands of arachnoid are adherent, and just using a gentle forceps spreading technique, we find the pericallosal arteries and the corpus callosum. And then we'll carefully do our corpus callosotomy. Now, when you do the callosotomy, you'll land in one of the ventricles, and you have to figure out which ventricle you're in, and you have to get control of the septum. So once you're in one side of the ventricle, you have to open up the callosotomy to get to the other side so you can see the septum pellucidum. Once you see the septum pellucidum, we separate the two leaflets. This is what I call interseptal dissection. I use a fine microforceps, separate the leaflets of the septum. And meanwhile, I'm always keeping a direct view of where the fornices are. The fornices are at the base of the septum. And if you remember the anatomy, the septum, the fornices will grow farther apart as you go from anterior to posterior. So it's a little safer to separate them more posteriorly. And once you separate them and you enter the roof of the third ventricle, I put these small sponges. They look like gel foam, but it's not gel foam. These are called bical. Bical sponges are not adherent, whereas gel foam is very adherent after a long case. It's harder to remove. So these are much easier to remove. If you don't have bicol, you can alternatively use Duragen. So you can cut the Duragen into small pieces, quarter by quarter, and you could use these as spacers. It keeps your interseptal window open. And so I've identified the cyst. I saw the internal cerebral veins earlier. So this is actually a pineal cyst. It had a very thick wall. Most pineal cysts we don't operate on. We generally monitor them, but this is one of the rare instances where it has grown and caused obstructive hydrocephalus. And these you have to remove. So you could see we saw the cerebral aqueduct earlier, and now we're going to peel the cyst off of the floor of the third ventricle. Now, posteriorly, behind the cerebral aqueduct is the posterior commissure. So this is the posterior commissure, this is the cerebral aqueduct, and this is the tegmentum of the midbrain. So you don't want to injure the tegmentum, so you have to just, using fine forceps, just carefully separate. And in the lateral position, you can see how this opens up nicely. By gravity, the septum falls away from the other septum. And using these bicol or Duragen spacers, we now see the final attachment. You could see those perforators usually in the back. You can't pull these. You have to cauterize and separate it because there's vascularity in that posterior attachment. There's the internal cerebral vein. You don't want to injure that either. And then here's the final view, final delivery of this pineal cyst. And you could see once the cyst has collapsed, it's actually quite thick. It's actually like a mass. So cyst aspiration doesn't work either. So don't try cyst aspiration. That's a futile treatment, in my opinion. So there's the final view. You can see the two septums of the leaflets of the septum pellucidum, the foramen Monroe and the fornix are intact on both sides. And again, a spectacular view of the ventricular system here. So we recharge the ventricles with saline, recharge the CSF, and sometimes I'll put a little gel foam over the callosotomy to prevent a subdural effusion. And then here's the 3-month post-op scan. You can see complete removal and did not require a shunt. This is another third ventricular lesion posteriorly. This was an ependymoma. This was one of my earlier cases. She did have an SMA syndrome, I think from frontal lobe manipulation or retraction, but it did recover at 3 months. Here's another case. This is an interesting lesion. Look at this T2. This was a patient who presented to another surgeon with acute hydrocephalus, and the other surgeon did an ETV to treat the hydrocephalus, but there was no biopsy done. So we had no idea what this was. I think because of the location, a biopsy was not done because it looks like it's in the periaqueductal gray matter, or it was actually in the cerebral aqueduct. So the lesion, the hydrocephalus resolved, but that lesion in the mesencephalon was growing. You can see it's gotten bigger on this heavily weighted T2 image. And so I went ahead and did a transcallosal interforniceal approach, and I went through the aqueduct. I removed the tumor, and I got into the fourth ventricle from there, and I left a small remnant stuck to the wall of the aqueduct. I didn't want to injure the surrounding structure, so I did a near total removal, and this ended up to be a rosette forming glioneuronal tumor, which is a benign tumor. And he did great and didn't have any deficits after that. So we talked mostly about tumors. Sometimes you'll encounter a vascular lesion in the ventricular system. This gentleman had a cavernoma in the mesencephalon, and he was having repeated hemorrhages that gave him a left third nerve palsy, right hemiparesis paresis. And you could see, how do you treat something like this? I showed this to a number of colleagues, and several colleagues said, well, they would come in from a contralateral OZ transylvian. Some colleagues said they would do a lateral supracerebellar infratentorial. And I just felt, with these two approaches, although it's feasible, the pitfalls of the approach from the contralateral interpeduncular space is that you're going to have the basilar artery and some P1 perforators in your way here, which I thought were risky. And coming through here, there's quite a bit of distance of normal neural tissue before you get to the cavernoma. Well, when I looked carefully on the imaging, you could see it actually presented itself to the third ventricle, and it presented itself to the left wall of the third ventricle. So I felt that coming from a contralateral transcallosal interfornical approach, I would have the best angle, and the cavernoma would be right in our view, which indeed it was. It was right there. I didn't have to violate any brain tissue. It presented itself to the surface. And to be honest, the case was actually very easy. It was all about choosing the right approach. And once you get into the cavernoma, the rest is pretty easy. It was soft. It had a lot of hemorrhage in it. It decompressed itself. And I just had to peel it off of the neural tissue using the techniques I showed you earlier. And this is him at 6 weeks post-op. He regained actually a lot of his deficits from that. So the posterior third ventricle, we talked about the different approaches. This is a classic supratentorial, supracerebellar infratentorial. You can come in interhemispheric occipital transtentorial, or you can come in posterior interhemispheric transcallosal through the splenium, or you can go in anterior interhemispheric, which I showed you for these lesions. Again, you know the anatomy of the third ventricle here. When you turn the patient on the side, it's important to understand the anatomy on the side. I showed you in the previous pineal cyst case that the cerebral aqueduct will have this opening that looks like this, and just behind it is the posterior commissure and then the pineal gland in the pineal cistern. You can see the perforators here coming off of those posterior medial choroidals. And so the trajectory to the posterior third ventricle from an anterior transcallosal approach has this type of angle, which is very, very doable. It's important to preserve the paired internal cerebral veins. And again, I like to take the craniotomy across the midline to be able to separate, to be able to retract the superior sagittal sinus over. So there's the tumor that you see here in the posterior third ventricle. Here's the post-op complete removal. This is a case we published some time ago on a papillary tumor of the pineal region. These are benign tumors. They're curable tumors, not malignant. So a complete removal will result in a cure. So again, the patient in the lateral position, dissection of the interhemispheric fissure. You see the beautiful paired pericallosal arteries. And it's easier to separate when they're in the lateral position. Just use a forceps, separate the arachnoid, and you'll find the nice shiny white color of the corpus callosum will drop into one of the ventricles here. And we find the other ventricle on the other side. So now we separate the two leaflets of the septum pellucidum. This is the interseptal dissection. And when you find the roof of the third ventricle, you have to know each layer. So the first layer is a arachnoid layer called the telochoroidea. And you open up that layer of arachnoid, then you will see the paired internal cerebral veins in the potential space, which is the velum interpositum. And then below the internal cerebral veins is another layer of arachnoid. This is the second layer of telochoroidea. So the two layers form that velum interpositum. And once you get through the deeper layer of arachnoid, you see the tumor in the third ventricle. So there's the tumor in the third ventricle. This is a solid tumor, not cystic. We're going to find and control the anterior pole of the tumor that's on the right of the screen. We're going to debulk the tumor, take some biopsies, and debulk the tumor, and then start to control the posterior pole of the tumor. There's the posterior pole of the tumor. There again is those perforating arteries, which you'll see in a moment. We're going to cauterize those posterior medial choroidal perforators that are attached to the back of the tumor. This is the ultrasonic aspirator debulking the tumor. And then this is all done retractorless. There's the last perforator. And then we'll just remove it in a piecemeal fashion. And then at the end, we get everything dried up. You'll see the beautiful anatomy of the third ventricle. There's the cerebral aqueduct. There's the posterior commissure, and there's the pineal recess, just the way we saw it in the Roten Atlas. So being able to understand the normal anatomy and apply it to a pathological condition in your surgeries. So here's the post-op scan. You can see a complete removal. There's the callosotomy, gives you a rough idea of the size of the callosotomy and the trajectory of the bone flap. This was a tumor I did recently. This was a metastatic lung carcinoma. You could see I took an anterior transcallosal route, and I was able to reach all the way in the back. You can see tumor was mostly in the third, posterior third, maybe even the mid third ventricle. So I really like that approach, as you can see. Let's change topics for a little bit. This is an area in the pineal region, the falcotentorial meningiomas. These can be treacherous tumors, namely because they arise from the falx, or they can arise from the tentorium, or they arise from both falx and tentorium. They can often involve, or sometimes even invade, the vein of Galen complex. Sometimes you can get pineal region meningiomas that arise from arachnoid cap cells in the velum interpositum. These are called velum interpositum meningiomas. And sometimes you can get tumors that recur in the velum interpositum as well, patients who've had previous tumor resections that recur. So knowledge of the position of the vein of Galen is very critical. I usually study the veins on a CT venogram or sometimes conventional angiogram, but you have to preserve the internal cerebral vein as it goes to the vein of Galen and into the straight sinus. So here's a patient with a falcotentorial meningioma. It grew from 2012 to 2015. And here we're going to use a lateral approach. We're going to go transfalcine to get to the opposite side. And remember when I said I like to keep the bigger side of the tumor on the top side? So in this case, that's the right side is bigger. So we're going to use an approach from the left side and position the patient with the right side up. So the bigger part of the tumor is going to fall down. You can find the full video here on this article we published in Neurosurgical Focus. There is the extracapsular portion of the tumor. There's the splenium of the corpus callosum. And we'll dissect it away from the retrocallosal component. This is the anterior pole of the tumor. We'll then cut through the falx. This is important to open up the falx so that you can get to the opposite side. And then we'll peel the tumor away from the splenium of the corpus callosum. We want to control the left lateral component off of the ipsilateral parietal lobe. And then there's the vein of Galen. So as you come around the backside of the tumor, be very, very careful. You want to look for that vein of Galen. Here, we're controlling the right part of the tumor. We're using gravity to fall down, and I'm using a pituitary forceps to bring it down, and then using the suction to dissect it off of the floor of the parietal lobe. Now, this is the part where the tumor is more treacherous. This is I'm not sure whether this tumor has invaded. the falcotentorial junction, but you could see I'm just trimming it. And I realize here, you could see there's this junction of the straight sinus and vein of Galen, just like in the Roten atlas. And I don't want to get into the venous system. So I just trim it, and I left a microscopic residue of tumor that's on the falcotentorial junction. You can see there's little microscopic tumor there. That's where the complex of veins are going. So we don't want to injure those veins or occlude them. And here's the post-op scan. And I treated the residue here with radiosurgery at 3 months. And he did incredibly well after this surgery. Here's another falcotentorial meningioma. This is an interesting case because look at the veins. The internal cerebral vein comes down out of the third ventricle, but disappears. I don't see any internal cerebral vein or vein of Galen, and then I see reconstitution of the straight sinus. There's a big inferior sagittal sinus here. So I wasn't sure if this vein of Galen was compressed or occluded. I just wasn't sure how this venous system was working. So I positioned the patient laterally. I've been using a more vertical incision rather than a horizontal. I just find this a little bit easier to do. I put in EVDs intraoperatively. Now this gives you direct relaxation of that parietal lobe. And you see how the brain is relaxed. You see the tumor coming from the falx. We'll debulk some of the tumor, and then I'm going to use the Doppler to map out where the straight sinus is so that I can make a safe incision in the falx. Once I make the incision in the falx, there's the tumor straddling the falx. I'm going to pull the tumor down from the opposite side using this Penfield 1 dissector and ultrasonic aspirator to debulk it. And then now I'm dissecting the internal cerebral veins. So remember, these internal cerebral veins I thought were collapsed. It's important not to cauterize the tumor. I think it's, we're always taught to cauterize these tumors, but I think if you cauterize the surface of the tumor too aggressively, you lose the visualization of the planes. So look here, this is the internal cerebral vein going into the vein of Galen. There's a vein here. And so you have to preserve it. I'm just separating the veins from the tumor. There's the internal cerebral vein from the front side. And I'm going to skeletonize the internal cerebral vein, and I'm leaving, this is the vein go from the front to up to Galen. And you can see I left a cuff of tumor, very microscopic residue on that vein. And this is the final view afterwards, brain untouched. But look at this, the CT venogram afterwards. Look how the internal cerebral vein is now reconstituted. And if you had coagulated the surface of the tumor too aggressively, you probably would have caused a venous injury. So fortunately, this patient did very well. This is her at 2 weeks post-op, no deficits, and a great result. This is another variation of a falcotentorial. This is primarily tentorial, but presents itself to the falcotentorial region. Here, I decided to do the right side down, mostly because the origin is tentorium, and it's hard to see the opposite tentorium in a lateral position. So you put, if it's a tentorially based meningioma, you put the ipsilateral side of the tumor on the downside. So this is the right parietal lobe that you see here. The tumor extends more laterally to the right. So we're going to bring the tumor up by pulling the tumor up and then carefully dissecting it from the parietal lobe. This is the anterior pole of the tumor, dissecting it from the brainstem, from the tentorial edge. And here, the vein is going to be draped over the top of the tumor. So some people say if the vein is draped over the top of the tumor, you come from supracerebellar, but you could still remove these tumors even if the vein is on the top. And I'll show you here the beautiful view of the veins. after we deliver this tumor. So this is after considerable debulking. You can then remove it. So here's the internal cerebral vein going into the vein of Galen. I had a little bleeding from the vein of Galen, but I just put a little gel foam and it stopped. And the vein was preserved. And with the endoscope, I had a great view. Here's the trochlear nerve, and then a beautiful view of the back of the brainstem. So here's the post-op scan, a complete removal. Here's some other examples of some. This one was a recurrent meningioma in the velum interpositum. Patient had a previous tentorial meningioma done at another hospital. And this one was interesting. This one was a Falcotentorial meningioma, recurrent, atypical meningioma. This was partially removed by another surgeon in the community, and it grew back, causing significant brainstem compression. Patient also had a Chiari with a syrinx. So I did a combined occipital and suboccipital craniotomy. I preserved the superior sagittal sinus and preserved the straight sinus. And I also took out the foramen magnum and C1. I coagulated the tonsils to treat the Chiari malformation that was acquired. And you can see post-op day 1, the syrinx had immediate resolution. And at 3 months, she regained her ability to walk. She was severely disabled preoperatively, but regained significant function post-op. So the key of the falcotentorial surgery is avoid the venous complications, avoid violating the deep venous structures. So this approach I showed you is also good for pineal region tumors. This is the approach I've been using now to avoid any venous air embolism using the lateral approach. This one was a pure germinoma, but by removing it, we were able to avoid hydrocephalus. I've also applied this approach to arteriovenous malformations of the superior vermian region. This is the transtentorial, interparietal transtentorial approach. This is to the superior vermis. So again, in the lateral position, you can find the distal SCA vessels that are coming off of the back of the brainstem. The beauty of this approach is you land right on the surface of the cerebellum, the superior surface of the vermis. We open up a corticectomy, and in a fresh hemorrhage, I believe that early surgery of AVM that have bled, you take advantage of the blood clot that is formed, because the blood clot has already dissected 6 of the 8 surfaces of the AVM for you, and it just makes the surgery easier for you. And this was a complete removal of the AVM and neurologically intact afterwards. This is a little bit bigger AVM. This is a complex vermian AVM. You could see there's a venous varix here, and variceal aneurysm located here. Here's the lateral projection. You could see big vascularity, draining vein here. But what's interesting here is there's no straight sinus. So this is an important feature. There was no straight sinus here. Here's the 3D. You can see there's no straight sinus. So we're using the interparietal transtentorial approach. There is the deep venous structures, the vein of Galen complex. That's the splenium of the corpus callosum. We're going to open up the tentorium now. This is the transtentorial cut, and you have to make it very deep in the longitudinal fashion. So you get wide exposure to control both anterior and posterior poles of the AVM. Now we're going to open up the falx to get to the other side. And I'm going to cut through the straight sinus here. There's no flow here. I mapped it out with a Doppler, and we studied the angiogram carefully. So by cutting the straight sinus, I'm able to get to the opposite side and control for the lateral extent of the AVM. And the rest is AVM surgery, which is careful cauterization of each feeder, carefully diffusing each arterial feeder going into the AVM. And my colleague, Dr. Candlewall here, did a beautiful embolization of this AVM. It made the surgery a lot easier for me. And there's the distal SCA. Now here's the draining vein. We've already controlled for most of the AVM, so now I'm going to take the draining vein to release it. And you'll see that the AVM actually gets very close to the fourth ventricle. You'll see the fourth ventricle being exposed here. There's the fourth ventricle in the depths. And here's the final removal of the AVM. And little surgeon cell. And you can see the brain untouched. Here's the post-op angiogram, complete removal. And she had a little bit of ataxia. So this is the last case I want to show. This is an unusual looking AVM. It was patient had seizure-like symptoms with episodes of sleep paralysis. Other than that, she was neurologically intact. But she had this very dangerous looking lesion. Look at the falx, how it's widened, and it's got these flow voids in the falx, and it presents itself to this huge venous varix. Here's the angiogram. You can see fed by the internal cerebral artery, or ICA, going into this malformation here with a huge venous varicose, dilated, tortuous venous varix going into the vein of Galen system. So believe it or not, the first person who did the angiogram for me came to the room and told me that this was a vein of Galen malformation. And then this case was circulated around the country amongst very prominent endovascular surgeons who called this, some called it a dural AV fistula. So this is very critical because if you treat this as a dural AV fistula, you would occlude the venous system. I can tell you if you occluded the venous system, the patient would have died on the table, because I'll show you in the video that when I tried to put a clip around the vein here, the patient's brain swelled instantly and started bleeding from the superior sagittal sinus, and I quickly removed the clip. So this is not a dural AV fistula. This is an AVM with a draining vein. So it's very important that you get the correct diagnosis. I think it was easily, you could be easily fooled because of these dural feeders going into the falx. Gives you the sense that this is a dural AV fistula. But nevertheless, this is an AVM. So we did staged transarterial embolizations before going into surgery, but this was fed from pretty much every vessel, both externals, the internals, and the vertebral injection as well. So this is the 3D. You can see the AVM is arising from the falx and has a complex venous drainage here. So this is the transfalcine pericallosal AVM. It was not in the parenchyma. This AVM was in the subarachnoid space. And again, the diagnosis is critical to success here. So after stage embolization, we took the patient to surgery. This is a lateral approach. The left side is down. So anterior is this side, posterior is this side. So we're now controlling for the anterior component of the AVM. You can see here's the falx, and here is the perifalcine AVM, pericallosal AVM. We're shrinking the AVM, cauterizing it, and taking out stepwise devascularization of the feeders coming from the distal ACAs. These distal ACAs go right into the AVM. We'll cauterize and divide it sharply. And separate it from the ipsilateral frontal lobe. And here's the draining vein here. You see, now I'm dissecting away. This is that draining varix. I'm isolating it. And so we'll do a ICG. You see, this is the falx, and it's coming out through this vein. And I put a clip, the video stops here, but I put a clip on it, and the brain almost exploded. So I had to take the clip off, and I had to give mannitol and wait another 30 minutes before the brain relaxed itself again. Then I was able to resume, but now I'm cutting the falx. And as you remember, the falx is completely vascularized. And this is where trouble starts to happen. The falx is quite vascular, and I'm having trouble devascularizing the falx. I tried to put a clip on the falx, and I made the tear wider. So what is the problem here? The problem is these bipolars, straight bipolar tips, don't have the right angle in an interhemispheric approach. That's the lesson learned here. So I call for the angled bipolars. They're not in the room, but if you put a little gel foam and just hold pressure, you stop the bleeding. And again, you can see these straight tips are futile. And the flow of the artery is overpowering the ability of the bipolars to work. So what I do is I use adenosine arrest. It's a good trick. It slows the heart rate down to lower the blood pressure so that the flow does not overpower your bipolar's ability to cauterize. So once I give a few adenosine pauses, the angled bipolars are finally arrived in the room, and I'm able to control the bleeding and resume the surgery. So remember to have angled bipolars when you're doing interhemispheric surgery, especially for these cauterizing the falx. So once you open up the falx, I have control over the contralateral surface of the AVM. And then I can come around the backside. So I'm cutting around the falx now, going towards the back, and then dividing it here as well. And what you're seeing here is the corpus callosum. This is the white color of the corpus callosum. And now here's the draining vein. So how do you know you devascularized enough AVM to safely take the draining vein? Well, you could do a clip test or a pinch test. Watch the AVM as it swells. You see that? I do a pinch test and the AVM swells, which means there's still a lot of AVM to devascularize. So, and as you can see, there was a huge feeder around the backside, which I didn't take out adequately yet. So now I'm gonna take out the last portions of the arterial feeder. And now I do the pinch test again, and now the AVM does not swell. So now I know it's safe to take the draining vein. This is a big vein, so I'm going to use a permanent straight clip here and make sure that vein's occluded, and then I can cut the draining vein. You can see it's a big vein here, big lumen. And final removal. This is disarming a big bomb. And there's the view. Spectacular view. Interhemispheric, no violation of brain tissue, working in a deep crevice like a mountaineer. And the brain is untouched, you can see. So here's the postoperative angiogram. No more AVM. And she did great from surgery. She had a tiny stroke from her first embolization, but no strokes from the actual surgery. So in conclusion, the interhemispheric approaches can be safely navigated to reach these deep targets in the brain. These are natural corridors that can be expanded by either incising the falx or the tentorium. The lateral position is great for gravity assistance, and you should drain the CSF, whether it's through an EVD or a lumbar drain, to really get that brain to open up from the falx. And the endoscope is very useful. I use it almost every case to look around the corners to inspect the cavity. And again, veins are the most important here. You must preserve these deep venous structures and gently handling of the tissues. You can catch the all of the old webcasts on Neurosurgical TV on YouTube, and we have more to come. And I thank you for your attention. I welcome any questions and comments. And I know Rafael has a beautiful corollary case to show. Thank you very much.
Okay, James, great. Do you want to go with Raphael's presentation or do you want to go to questions?
Why don't we have Rafael's case first, and then we'll open up for questions after.
Okay, Raphael, it's all yours.
Well, thank you very much. Both beautiful videos, Jim. I would love to ask you some question later. Especially, I was very interested when you were talking about the coming from anterior transcallosal to open more kind of the midline of the transcallosal. So just gonna show my video. Yeah. Can you guys see my screen now?
Not yet.
What about now?
Not yet.
You don't see it?
No.
I see your screen. I see your desktop. I see your desktop.
Yeah, we don't see the video playing. It looks like you're not opening it yet. Click on it a couple times. There we go.
Okay.
We got it.
Now?
Yeah.
Yeah.
Oh, this is a case of a patient that I did recently. This is a patient in the third decade of her life. She comes with this small falcotentorial meningioma. We position her in lateral position as Jim described with this linear incision. I think it preserved the hair much better. This is the plank craniotomy, right parietal. In this case, it's a left parietal in the picture, but so I like to do the incision parallel to the sinus. I think that provides me with a good view of the veins joining the sinus in this case, allow me to retract, and at the end, I just need to approximate the dura. This patient present with some degree of hydrocephalus, so we just place a external ventricular drain, and we just carefully dissecting the adjacent veins to the sagittal sinus. Important to know that always the vein that runs parallel to the sinus, you usually have a very long track, so it's important to just spend the time to just delineate these veins well in order to approach the interhemispheric corridor. As you see, like after drainage of some CSF, we have a nice corridor here. I'm mapping the sinus rectus, and I mark it as to localize and have an orientation of the view. Now the microscope is tilted anteriorly, and I rather prefer to use this with a cottonoid to start delineating the veins. Here you see the internal cerebral vein. The vein of Galen is pushed up. That is the corpus callosum, this planing of the corpus callosum. So now I'm just going to dissect a little bit and open the surrognoid space there, because I feel it's what's going to be very difficult when there's more blood in the space. So I just do under very high magnification to just delineate the tumor from the internal cerebral vein. This is probably the superior cerebellar vein that goes posteriorly, as you see, and then the occipital vein. As you know, the superior cerebellar vein can be coagulated without much of a deficit, but just for better orientation, we just decided to preserve it. I still cannot see the vein of Galen as per the angiogram. I know that it's pushed up. I just place a cottonoid here to just preserve that surrognoid space. So now I'm going to be able to dissect all the way from the back to the front. So I mark again my sinus rectus. Now I proceed with coagulation of the tentorium. It's important to know that here you need to spend a lot of time doing the coagulation because the tentorium it's two leaflet of dura between which there is a venous sinus, and so you need to spend your time coagulating there because this is an area that very likely is going to bleed. I just create an incision in the middle of the tumor to reach the tentorium in an area that I feel is safe. I'm away from the venous extractors, and this is what I'm going to do to flip the tumor up. Further proceed with this arachnoid knife to delineate the tumor, always, being aware where the sinus rectus is. In this case, this is a purely tentorial meningioma. It's a falcotentorial per classification, but it's not invaded the sinus rectus, so we don't need to open the falx. Now, the microscope is tilted again, a little bit more anterior, and I'm going to complete my subarachnoid dissection of the tumor. That allows me to preserve the superior cerebellar vein that was running close to the tumor. Here I use a number 14, use a dissector or any feather blade to dissect the tumor away. And I feel that at this point, I've been able to dissect the tumor from the venous complex. And now we're still seeing the tumor from front to back. This is the corpus callosum on the left, the chunk of the tumor on the right. And I proceed with some dissection. This is a side cutter aspirator that works pretty much as a sonic aspirator. We need to do some debulking to minimize the manipulation around the brain and the cerebellum. Do internal coagulation. I just feel that it keeps the tumor under control. And here is where I spread the tumor. I think it's going to make my case easier if I divide the tumor into small pieces. So I continue the dissection anteriorly into the edge of the tentorium. And as I move in anterior, at some point, we need to cut the tentorium edge in order to flip the tumor around. So now this is, again, the back of this anterior half of the tumor. You see with Yusuf for dissector, we're able to sneak under the tentorium, and the tumor is attached to the tentorium. So at this point, it's fully devascularized, and we just need to do sharp dissection, always recommended to avoid losing the plane. And this is an area that at this point is already devascularized, so it should be easier. You see that just a little bit of touching with the scissor, as Jim described it. It's important to handle the scissor correctly so you avoid several changes between dissector, scissor. You can pretty much always, you can use as a tweezer, you can use as a forceps, you can use as a scissor itself, and you can use as a dissector. And you move anterior into the direction of the tentorium and the edge of the tentorium, and here you see the internal cerebral veins going down, and upward you have the vein of Galen. So when choosing this approach, I think it's important to note here especially that it's not that you see the veins in front of the tumor or behind of the tumor, or the tumor are above the veins are above the tumor or below. I think they are lateral itself, so you can have a nice view of the tumor and the veins, but you don't need to pick into between going above and below. That's the defense of the supracerebellar approach. But I think with this approach, it's very nice to see the veins all the way laterally, and you can still preserve a good visualization of the top of the cerebellum. Here you see the forecorner nerve that is running underneath. We're just peeling the last branches of the SCA. We're going to the contralateral side. That is the edge of the mesencephalon and the pineal gland. The superior and inferior colliculi. It's important to do at this point. Always the patient can wake up with some symptom associated to the manipulation of the superior colliculi, such as vertigo and double vision. Important to minimize the bipolar at this stage. And as you remember, we divide the tumor into pieces. Here is the surgical cavity, but there is still a piece of the tumor that I left for the end to dissect this very distal branch of the SCA. Honestly, if taking this artery that distal probably wouldn't cause much of a deficit, but it's important to just always try to maximize surgical technique. And this is the final view. You see what is the Y corridor that we have when doing supratentorial and entire parietal dissection, how the corpus callosum is preserved on the left side. The patient did very well, went home the POD2 and recovered without deficits. So thank you very much. I will be also open to some question and discussion. Well, Gene, thank you very much for all your insight and always, being available to answer some of my questions as well when talking about all this tumor. I would like to ask you, well, when we talk about the lumbar drains and when to use a external ventricular drain, you advised to me to, in this case, use an external ventricular drain up front, which is, of course, in this case, there is a Chiari associated that has a lot of relevance. But would you use now or in your current practice external ventricular drain rather than lumbar drain? Do you feel this? What is your rationale about it?
Yeah, I think if they have pre-existing dilated ventricles, using a ventricular drain, I think, is more appropriate. And you could do it after you open the dura with the stealth. You don't have to drill a separate hole. You just do the craniotomy, open the dura, and just put the drain right there, just a little bit lateral to your inner hemispheric fissure. It works just fine. I think if there's no hydrocephalus, then in the lateral position, you may not even need a lumbar drain. You can just put a spinal needle and then just let it drain through the needle, which is an old trick. You don't have to necessarily put an indwelling drain, but you can if you want to. I thought your case was beautifully done, masterfully done. I thought it was very interesting that you couldn't see the vein initially, but after some decompression, the vein of Galen started to appear before you in the anterior pole of the tumor. My question for you is, how did you determine in the lateral position which side you're going to put up and which side you're going to put down, especially if it's nearly symmetric? I was curious as your thought process on that.
Well, and this is exactly what you said before, right? In this case, I feel that the largest part of the tumor need to be in the lower, like the large part of the tumor needs to be in the lower side of the gravity, so per se, so you can move the brain away from you. But this is in particular just for purely tentorial meningiomas. Probably this is more, as you say, falcotentorial meningioma that is coming from both sides. I would choose the side that has the larger part of the tumor up. But like I said, this is probably a little bit special, and you could tell more about it. I think that's probably what you do as well, right?
Yeah, if it's intraventricular tumor, I do the larger side on the superior side. But if it's tentorially based, the tentorium fixes the tumor. It doesn't fall down by gravity. So if it's tentorially anchored, I put the larger side on the ipsilateral dependent side on the lower side, like you did.
Mm-hmm. I found also very interesting when you were talking about that in the post-op, oftentimes this vein of Galen, if it's not there, or the vessel veins, once you remove the tumor, they appear. And we don't truly know what happened if we take dead cerebral veins. Fortunately, we don't know. I guess sometimes we know, unfortunately, there are patients who might have a very bad outcome if many veins are involved and so on. But I think that another learning point from your cases is that even on a CT angiogram, especially when you don't see the vessel vein or the vein of Galen, I don't think that should mean much. I think that as you go into the field, you need to try to preserve those veins, but probably it would be slightly different if it's the sinus rectus. Probably we have a lower threshold to take the sinus rectus down. But this is just my, my experience with you. I have another case that seems that the sinus rectus was involved and the vessel vein was also involved. And after you decompress the tumor, you start seeing those veins. So I don't know what would have happened if I took those veins, but I think that the intraoperative field is completely different than what you see in the angiogram. What do you think about that?
I think the veins, the veins can always bite you in the back when you're not least expected. But I agree, you have to try to preserve as much vasculature as possible. I try not to take the veins. There was one tumor, the recurrent falcotentorial, that looked like pieces of the inferior pieces of the straight sinus looked like occluded, and I just follow the tumor. I think there's always microscopic venous collaterals in the tentorium that you don't see on an angiogram. So I try not to be too aggressive with those. There could be some, kind of like when you see parasagittal meningiomas that invade the sinus. I believe that there are some channels along the leaflets of the sinus sometimes. And so I don't always resect the sagittal sinus. I remove the tumor and I follow it in, but I try not to take it. I fear that there might be some venous collaterals. But the only time I've taken the straight sinus is that AVM case I showed you, because I felt that was the only way to take out the AVM, and I felt confident there was no flow in the sinus rectus. Professor Suresh.
Yeah, so
Hi.
great talk, James. Enjoyed it. Couple of questions and comments. So you started by telling you showed a large neurocytoma, the frontal horn, and you told your preferred approach is still interhemispheric. When the whole lecture was on interhemispheric approach only, but you showed the blind area in large neurocytoma, the frontal horn. But always we feel if the tumor is falling, a interhemispheric approach is extremely good. Sometimes if it doesn't fall, I think transcortical still has a role because you get access to the most lateral aspect of the tumor with a transcortical approach than an interhemispheric approach. I'll get your comments later. Then you showed you are a great fan of not only interhemispheric, interfornicial approach, which is many of us have left that approach some time back for fear of memory problem. Obviously, you are great technical expert. Your patients would not have had much problems post-op. My question to you, you made a passing mention of sacrificing septal vein. So if you sacrifice a septal vein, you can open the choroidal fissure anteriorly. It opens into foramen Monro. So have you tried sacrificing choroidal septal vein and opening the anterior part of the choroidal fissure and going again through transchoroidal route instead of interfornicial route? You can get these comments answered to me later. Next thing is, I pursue. You do all cases you do of your meningiomas, velum interpositum, falcotentorial. You showed everything. You will do a DSA study to see the venous system. And the classical teaching, which I have taught people and all for, the velum interpositum and falcotentorial are difficult. You showed that if the venous system is displaced inferiorly, as in falcotentorial, you come from above. If it is displaced posterior superiorly, as in velum interpositum, you take a supracerebellar route. This is the classical teaching. We're not all good always. We have told so many examples. But sometimes, I don't know, velum interpositum are two layers of, it's between two layers of pia, superior and inferior layer of pia matter. And you have tumors usually arising from the inferior layer of velum. So it again pushes the both medial posterior choroidal and internal cerebral vein posterior superiorly. But very rarely it can arise from the superior leaf when there can be splaying of medial posterior choroidal and internal cerebral vein. And very rare tumors also. So in such situation, what approach will you do? And every difficult tumor you showed, all AVMs you showed, I appreciated. Only thing which I thought would have completed is a large trigonal meningioma, which is again a difficult tumor. Say, I presume you come from the contralateral side and do a precuneus approach and enter the ventricle, or again you come from a superior parietal lobule approach. Comments, James. Your
Thank you
opinion.
for, yeah. Thank you for your comments, Suresh. Yeah, I think you've addressed a lot of points. I think the in terms of the Falcotentorial, the position of the vein of Galen is important, but I've transitioned to pure, almost coming in purely interparietal, interhemispheric from above. I've shied away from doing supracerebellar infratentorial sitting position, semi-sitting, only because of the avoidance of venous air embolism complication. I had one very, tragic one in my series, and I think because of that, I've preferred to do lateral position. I think it's safer. The In terms of the intraventricular atrial meningiomas, I think they are challenging. Even with a superior parietal lobule approach, you still run the risk of visual field loss from violation of the visual field fibers. So I think doing the interhemispheric precuneal approach is a useful trajectory. I think that's one approach that should be learned and mastered to do atrial tumors. It's not the most common approach that's used. I think most surgeons that I've spoken to use a transcortical route to the atrium, because it's easier, it's shorter distance, but there is the risk of visual tract fiber violation. So
Now, septal vein.
yeah.
So, sacrificing septal vein and opening anterior part of the choroidal fissure.
Yeah, that's also a very useful technique. I think it works well. It really widens that transforaminal corridor. It's probably
You can
less
avoid,
risk to the.
you can avoid splitting the going in the fornicial if you do that.
Yes, yes, of course. I think you can. And I think that's a very, useful approach. I don't use it as much. I tend to come interfornicile for a lot of lesions, because it gives me more of a midline orientation. The transchoroidal, you have more of an oblique view. You see more cross court, but the ipsilateral side, sometimes it's harder to see. But both are very good approaches.
What are your indications for transcortical approach for these type of lesions? Any indication for you?
I think if, like you said, if the lesion presents itself very lateral in the frontal horn, it's right there on the surface, then I'll go transcortical. I think you need a good dilated ventricle to go transcortical as well. So I do use transcortical for a large number of lesions. I just didn't show it here in this lecture, but a lot of intraventricular, gliomas, high-grade gliomas I've done transcortical.
Okay, Aravic, do you have any comments?
Yeah, of course. First of all, I would like to say thank you to both Dr. Liu and Dr. Martinez Perez. It was like very impressive, and I really like both talks. And maybe I can ask one question for both of you. So I would like to know the surgical approach order in cases involving both infra and supratentorial compartments. So is there a preferred sequence of approach if the tumor involves both infra and supratentorial? Because does it depend on the lesion type, or maybe vascular supply, or the risk of brain shift?
So I'll try to answer that first. I think first you want to pick your trajectory to the tumor. It really depends on the size, extent, and where you're going. I think for these falcotentorial meningiomas that both Raphael and I showed, the trajectory coming from above the tentorium will take you to the bottom part of the tumor adequately. So we're using a supratentorial approach and going through the tentorium, transtentorial, to get to the infratentorial compartment. There are some tumors that I think you have to have control of both sides. And the case I showed that was very extensive, that was a recurrent tumor, pushing the cerebellum through the foramen magnum. That one, I did a combined supra and infra because of the trajectory of the tumor. The trajectory of my approach required that I had control suboccipital below the tentorium. And I also wanted to treat the tonsillar herniation through the foramen magnum. So in that case, I used a combined. But a lot of it is dependent on where you're going, your trajectory, and what kind of window you need to create to achieve what you need to achieve. So that's kind of how I think about it.
Okay, perfect. Thank you so much. And another question is for the staged embolization for the AVMs that you mentioned, you used that in that case that you showed. And what do you consider the ideal time frame, like the interval between stages to balance the safety and efficacy? Because sometimes if you wait for too long, it could be not safe anymore. And like, what is the perfect time frame?
Yeah, I don't know if anyone knows the real answer to that. I think in terms of staging, in this case, this was a outpatient elective procedure. So, I think we did the embolization in maybe 2 or 3 stages, if I recall. And it really depends on number of feeders. So this thing obviously was fed from many, many feeders. So we did the pericallosal feeders first, and then we did the external feeders, one on each side as the staged, and then we did the surgery, I think the day after the third stage. So it all happened, within, weeks of each other, months of each other. So I don't think there's a real right or wrong answer to that. This was an unruptured, AVM, but certainly, you don't want to embolize and wait too long. I think if you're going to embolize, you should, operate, within days of the most recent embolization.
Harshad, do you have any comments?
Hi, James. How are you? Wonderful
Good.
talk, as always. Superb lectures, and just again, I'm a great fan of a supracerebellar infertentorial approach, and my usual we don't have too much worry about the air embolism in our setup. What you said. Now there were 2, 3 cases. One is meningioma, one was a metastasis. What made you to think that you should go interhemispheric and not that supracerebellar?
Well, it depends on the presentation of the lesion. If the lesion is primarily in the posterior third ventricle, there's more anterior extension. I think coming in anterior transcallosal for me, it's very reachable. It's not too much of a long reach. That's just been my preferred approach, so to speak. And even with the falcotentorial coming
Yes.
in interparietal, it just makes sense to me, being able to control the tentorium, control the deep venous structures.
Okay, we have a question from Ibrahima. Could you please identify yourself and ask the question?
Hi, John. Thank you. Thank you for giving me the speech. And I would like to thank Professor James for this always wonderful presentation. We learn a lot from you. I think you are a legend for us, giving us a lot of opportunity to have like a lot of meaning and grow in terms of microsurgical. I'm Ibrahim, I'm a neurosurgeon from Guinea. So I would like to ask Professor James two of my questions. One is about the time about your surgery and how long we take the surgery between the stages, between the opening and to the closure of the surgery. And the second one is about the pineal region tumors. And usually if the tumor is associated with hydrocephalus, usually do you go often to resect the tumor, and then after that, do you keep the drainage after the surgery or not? Or because sometimes if the tumor is occluded between this location of the tumor, sometimes you can resolve the hydrocephalus. So what is your approach about all these techniques? And thank you again for this wonderful speech.
Thank you, Ibrahim. Thank you for participating and your comments. In terms of the timing of each component of the surgery, I would say the positioning and the preparation is about 2 hours if you include anesthesia's component as well. And the opening, usually these openings are very quick. It's not a skull base opening, it's just a simple superficial craniotomy. So that probably takes about 30 minutes, 40 minutes to get to the dural opening. And then the actual tumor removal under the microscope, it can vary. I think for colloid cyst, for me, it's about, an hour to hour and a half. And then for these larger tumors, probably somewhere between 2 to 3 or sometimes 4 hours if it's more complex. And of course, the closure probably takes about an hour or less. And in terms of the ventricular system, if they come into the hospital through the emergency room and they're obtunded, we will put a ventricular drain in at the bedside in the ICU. And after the surgery, I would leave the ventricular drain in place, but I leave it clamped. And I do a fast wean. So I clamp it for at least 2 days. And if there's no symptoms or development of postoperative hydrocephalus, I pull the drain. But if it's an elective surgery and there's no symptomatic hydrocephalus, in my early part of my career, I would leave a ventricular drain in the ventricle and then remove it the day after. But nowadays, I don't leave the ventricular drain and I just pull it. So at the time of surgery.
Okay, James, you're reaching Africa. Thanks, Ibrahima. I think
Thank you.
Raphael has a follow-up question.
Thank you again, Professor James. The other question, sorry, I would like to ask, how about the technique of the microsurgical and the endoscopic together? Usually, do you have like hand assistant or you use like chopstick technique?
Well, I would say for this, I'm most of the time when I'm using the endoscope, it's for inspection. Now, on some instances, you may need the endoscope to view and you see something and you have to remove it. You can either go back to the microscope to remove it, but if you can't see it with a microscope, you have to use the endoscope. So in those cases, you need a good assistant to hold the endoscope. So you can use two hands, suction in one hand and dissecting instrument in the opposite hand to remove what you cannot see with a microscope. So I don't use the chopsticks technique, but that's been very well popularized by our friend Dr. Fröhlich for pituitary tumors, but I have not used it for the cases that I showed you.
Okay, thank you. And also, sorry, and in terms of pathological diagnosis, usually in intraoperative diagnosis, do you often wait the result before continue the surgery? Because sometimes if the pathological have early result, sometimes you like maybe to continue or stop the surgery for like for secondary surgery. So how often is like the radiotherapy or something like that?
So I think your question was do you stop the surgery based on the frozen section result of the tumor?
That-
For example, if you run into a diagnosis of a germinoma, do you stop and do radiotherapy? I think you raise a great question. I think it depends on how much you trust your pathologist. Is very important. Sometimes they get the diagnosis incorrectly on a frozen section, but part of it is based on the tumor. So oftentimes, the case I showed you of the germinoma, the patient had obstructive hydrocephalus from the germinoma, and the tumor removal was actually not very difficult. So while we were there, it was very easy to remove the whole thing and relieve the hydrocephalus. So I think in that situation, I think that was a reasonable thing to do. And I've had cases where, you know, I debulked more volume of the tumor to relieve some mass effect, knowing that you know, whether it could be treated with adjuvant therapy. But I think many people do it different ways. Some people just simply stop at a biopsy, but I feel that if you're there and you have the head open and you're able to debulk more volume of tumor, only if you can do it safely. Obviously, if you're in an eloquent area, you can't do it safely. I think biopsy is your strategy, then that's what you should do.
Okay,
Thank
James,
you, Professor James. Thank you so much for this answering, and we are always happy to listen to you all time recording your videos. Thank you so much for that.
Okay, James, we have a question from Uday Bharti, a neurosurgeon from India. He says, can we use the transsulcal approach also?
Yes, of course, transsulcal approaches are very useful for subcortical lesions. I think it depends case by case, but yeah.
Okay. Any more comments or questions from the panelists? Okay, great presentation, James. Thanks a lot. And we'll see you in 2 weeks for another episode of Masterclass of Brain Surgery. And thanks, Raphael, for coming. Thanks, Aravik, Harshad, Ibrahima, Suresh, and all the other people on the panel and are watching this. So we'll see you in 2 weeks.
Thank you.
Thank you.
James.
Wonderful. Thank you. Wonderful.
Raphael. Thank you,
All right,
John.
thank you so much.
Thank you.
We'll see in 9 days' time at Boston.